For this lecture, we will cover the bronchoalveolar lavage fluid, also often referred to as a bronchwash. When analyzing bronchwash specimens, this helps us to obtain information like the cellular information, the immunological information, and different microbial information that can be revealed from the lining fluid of the lower respiratory tract. So a bronchoalveolar lavage is used in conjunction with high-resolution computerized tomography, in addition to the medical history and physical examination of the patient in order to determine if any sort of biopsy or anything is needed. So a lot of times this may be done as kind of like a pre-screening test to try to determine if anything suspicious on a chest x-ray needs or warrants further investigation or invasive procedures. So doing a what we also term a bronchwash and submitting that specimen to the laboratory helps us to look for some of the different things that could be causing problems within that patient, including any sort of interstitial lung disease, which could be coming from infections or different immunological or malignant processes, any kind of like airway diseases or anything that's affecting those alveoli or alveolar within that lung tissue, and also to look for any kind of the cystopathology type findings that you could find to indicate any sort of abnormalities or malignancies and things like that. So in order to collect these specimens, the clinician will actually use a fiber optic bronchoscope, which they will use to insert down into the lungs to get into that lower part of the lungs. And at that point, they will insert saline to kind of mix those cells up and to get a good sample of the fluid in that area. And then that's extracted out, and that is what's submitted to the lab. Now, those specimens should be kept at room temperature when being transported to the lab, and of course should be processed immediately. So typically these situations are going to happen in a hospital clinical setting in which these samples are going to be able to be looked at pretty quickly. If the delivery is going to take longer than 30 minutes to actually get to the lab to be evaluated, then it should be transported on ice to keep those cooler refrigerated temperatures. And you can also centrifuge and refrigerate those specimens if it's going to take longer than 24 hours before it can be analyzed. I don't know many situations where this might happen, because like I said, these procedures are usually going to take place in a hospital, so there's typically somebody there to process it immediately. Cell counts should be performed within an hour, but they are stable up to 3 hours if they are supplied to the laboratory in a nutrient broth. But again, I don't see cases where this will often be used. So counts for the white blood cell and red blood cell are done using the hemocytometer, so just like we do pretty much all of our other body fluids. And then the cell viability can be determined by adding any of the special dyes like the trypan blue. I don't know that many labs add dye to help with the visibility of those cells when they're doing a hemocytometer count, but some labs may still use those. So the diagnostic tests that we would do on a bronch specimen are pretty much similar to what we would do on any other body fluid. Of course, we're observing for color and clarity, which can give pretty immediate diagnostic information. When the clinician is collecting that specimen, if they see it come out real cloudy, then that automatically kind of gives them an idea that they are probably dealing with a lot of cellular elements within that sample. We would also do a cell count with differential, so that would involve using a hemocytometer, and those counts on the hemocytometer should agree within 10% of each other. So for example, if you count 50 white blood cells on one side of that hemocytometer, then the other side should match within 10%. So that will be plus or minus 5. So your second side should be between 45 and 55 in order for those counts to agree. If those counts do not meet this standard, then you shouldn't report it, which means you should do some troubleshooting. Maybe the sample wasn't well mixed, or you stopped in between and one side started to dry out. You took too long to do the count. So you want to make sure that those counts do agree within 10%. Microbial studies would be like cultures and sensitivities, gram stains, and those kinds of things, looking for any kind of fungal or bacterial growth within those specimens. And then your cytopathology, which is going to be more of looking for those malignant cells. Now granted, you can sometimes see those when you're doing the differential, but ultimately the pathologist will be the one to make that final diagnosis of any sort of malignancy. For color and clarity, pretty much the same criteria that we've used before. Looking for clarity for clear, hazy, cloudy, turbid, and we still use that criteria that we use for urine when we're kind of looking to judge clarity of a sample. And of course, color, it could range from a variety of colors. Obviously, if you see blood in the source, then that means there's some sort of hemorrhage within that lung, whether it was traumatic or something else that may be going on with the patient. Orange or red could indicate an older type of hemorrhage. Milky or light brown could indicate some type of protein problem going on within that patient. And of course, if there's presence of clots, that also should be noted. Now, of course, the site that you work at could have some different criteria as far as what they use to dilute out these specimens, but there are commercial type kits available, as well as just some other reagents that can be used to help with dilution of those white cells if you have high white counts, or if it's the specimen contains a lot of red cells, then you may need to lyse those red cells with some sort of reagent in order to do that count. And so when you do those counts, you will count all 18 squares, so 9 squares on each side for your total number. And then of course, once you get those counts, again, you want to make sure each side agrees within 10%. And then once you get those counts, then you would plug that into the formula. Pretty much similar, same formula that we've been using all along. And of course, this particular formula is counting for one side. So you would plug it in for side A and side B, get those results, and those results should be within 10% of each other. No more than 15 cell difference between the highest and the lowest number of those particular counts. And of course, once you've got those two counts, then you would, depending on what your criteria is for your site, you may report an average of those two, or you may do the total and do that division by 18 squares instead of 9. But your site will have specific formulas for these particular tests as far as what they want you to use in the reporting, and so that is what you will follow for your site. Your red blood cell count can be diluted just using your regular isotonic saline. And once you put that dilution onto your hemocytometer, and of course you may not need to dilute it, there may not be any red cells present. A lot of times we'll load it and look at it first just to determine if we need to do a dilution, and then if we do, then we will do the dilutions after we've first glanced at it. And of course, once you plate those cells, you do need to let them settle to be able to settle out all on one plane. And then you would do your counts and get those averages based on a number of cells that you count per side. And again, you could do them individually, side A, side B, and do that comparison to make sure you get within 10%. And then also you could do the total number as far as for your reporting. Now once you do your cell counts, you'll also need to do a differential. So you will make a cytospin slide, and you will look at those cells, stain those cells, and look at those cells to determine if there's anything that's suspicious, and you'll do those counts and get the average. Now the book does recommend 300 cells, but no, typically in a laboratory you're only going to do 100 and get the percentage out of those 100 cells. So when you're trying to classify the various white blood cells within that sample. And pathology could potentially do more, especially if they're doing any sort of special CD markers or special stains, looking for any sort of malignancy. Then they're going to do a little bit more of a larger count and looking at differentiating some of those different cells. With macrophages, you will see these as large cells that contain phagocytized material. And so these are going to be the most frequently cells that are going to be seen, and it can range anywhere from 56 to 80% of the cells that are going to be present. And so that phagocyte material could include hemosiderin, which is going to give like a golden brown or black pigment to whatever is inside of that cell. And then the cells also are going to have a foamy, frothy look, so they're going to be really large cells. Predominance of these cells are seen in smoking-related interstitial lung diseases, or it can also be seen in a rare lung cancer that contains the Langerhans cells, which would be seen more on the histological findings. In this particular image right here, you can see a lot of these larger cells that look like really, really large fried eggs. Those are going to be just normal macrophages. They're just kind of there at the ready to digest anything that could present down into those lungs, any kind of viruses, bacteria, anything like that, to try to contain it, dispose of it before it becomes a problem. And then of course you got the normal lymphocytes that are a little bit smaller in between some of those larger cells, so you can see an image of those. Lymphocytes should only include about 1 to 15% of the cell population when doing a differential. However, if you see increased cases, this could be suggestive of any sort of interstitial lung disease, drug reactions, pulmonary lymphoma, or non-bacterial infections, just like some viral or fungal type infections. If you have a cell count that's greater than or equal to 25% of this could indicate a granulomatous lung disease. And if it's greater than 50%, this could indicate a hypersensitivity pneumonitis or some sort of non-specific interstitial pneumonia. With our neutrophils, these are of course your primary granulocytes, and their normal value within the differential count is should be less than 3%. However, if you do see elevated percentages in patients, and you can usually see these with patients who are cigarette smokers, or in cases of things like bronchial pneumonia, toxic exposure, or any sort of damage within those lung cells. Counts greater than 50% can suggest some sort of acute lung injury, an aspiration of pneumonia, and any kind of supportive infection that's going on within that patient. So again, a lot of times if you see neutrophils in a high count in anything, it's going to indicate some sort of infection. With your eosinophils, these are usually going to be less than 1 to 2% of the total cells that are going to be counted. So out of your 100% count, less than 1 to 2% of those will actually be your eosinophils. However, if you do have elevation in those counts, and that could be suggestive of some kind of response, allergic type response like asthma or drug-induced lung disease, various infections or hypersensitivities. If you have counts greater than 25%, greater than or equal to 25%, then that could indicate an eosinophilic pneumonia or lung disease process that's taken place, so that would need further investigation. Mast cells, if those are present greater than 1% in combination with a lymphocyte count greater than 50% and with a combination of neutrophil count greater than 3%, then that's going to indicate a hypersensitivity pneumonitis, and so that would be treated for that specifically if it met all 3 of those criteria. Now, if you have the presence of erythrocytes or red blood cells within your sample, then of course that's going to indicate that there's some sort of hemorrhage going on, whether that's a traumatic tap or something else that's going on within those lungs. If those cells, of course, have been phagocytized, if those macrophages are eating it, or any cells you see are eating those cells, those red blood cells, then that indicates that that hemorrhage has taken place within the past 48 hours. However, if you start seeing it with that hemosiderin type laden macrophages, where you see that darker color, that brownish, orangish, blackish color within those cells, then that means that's an older type hemorrhage, so that's happened older than 48 or longer than 48 hours. When looking for the presence of epithelial cells, you're looking for ciliated columnar or bronchial epithelial cells. And so these are going to be the most numerous cell that's going to be present in any sort of bronch wash specimen. And that's just because of that technique of washing that cells. You think of like the inside of a washing machine. If stuff's sloughing around in there, then it's gonna stir up some cells. So these cells are going to be present in about 4 to 17% within that percentage of cells. And so these cells, you're going to see them within that cytospin slide when you make that, so you can kind of see where they're a little bit of a different shape. They're kind of pinched off a little bit. With our microbiology tests, we're still kind of looking for the same things we're always looking for in micro, looking for those fungal elements, bacterial or viral inclusions that could be present in that specimen. And of course, this also, by doing these microbial tests, it helps to give that preliminary results for cases like patients that are on a vent and have pneumonia. It helps to kind of narrow down what's causing that pneumonia to get that treatment initiated a little bit faster. And of course, we can see pneumocystis in our immunocompromised patients off of a bronch wash. And so here's an example of that. You can kind of see that little open area. You've got the large cell that's kind of off down to the lower left. And then in the center of that big mass, you got like a little bit of a clearing above that little darker spot there. And that clearing, let's see if I can get that circled here for you. That kind of suggests that pneumocystis kind of looks like a cup and saucer. You'll learn more about this once you actually get into micro. But that's typically going to be found in your immunocompromised patients. And of course, Cryptococcus, that will be more present in your AIDS patients. And of course, you're looking for that presence of that yeast in that specimen. Typically looking for Cryptococcus, though, you're going to do some sort of antigen testing or antigen titer to actually look for that in the patient versus doing the bronch wash, but it could be present on the bronch wash. And of course, cytology specimens, you're not going to deal much with this, but it is kind of good to know that these are the things that are going to, the testing done through a cytology point of view are going to be the tests that kind of help further diagnose what could be going on. So this is going to be looked at from a pathology standpoint, where they're just kind of looking for more specifically what some of those odd cells are, doing those special stains. If they were looking for the CD markers, that it could involve some flow cytometry. So all of this will just depend on where you're at. As far as if this is going to be done at your site, it could be something that's sent off to a separate site.